Hello, my name is Michael Burlow. I am a family nurse practitioner. I am the administrator and vice president of THEMA Hospice. THEMA actually stands, it's an acronym. It stands for THE was our owner and original founder, Teresa. And then MA stands for Dr. Margaret Irby, who was our first chief financial officer. We actually operate under the two different premises in Arizona. In central Arizona and southern Arizona, our locations are called THEMA Hospice. In northern Arizona, they're called Maggie's Hospice. Dr. Margaret passed away early in our operations, and so all our northern Arizona operations are named after her, so we're called Maggie's Hospice. I really want to thank you for being here today. And I really want to spread a lot of information about hospice, and in particular GIP hospice. But before I really kind of get into it, I have a disclaimer, and that is that the things that I'm going to tell you today pertain to this time period, which is September of 2023. All hospices are governed by Medicare, and Medicare rules change every year. So if you're watching this video in 2025, welcome to 2025, and coming from 2023, but rules could change. And so I just want to lay that premise out there. So to begin with, I feel like I'm in a very, very unique position to be talking about this subject, in particular GIP. About 15 years ago, I worked in our local hospice as a med-surg nurse, and at the time, they created an inpatient GIP unit, which I'll explain further as we go. But I worked as a med-surg nurse within the hospital, and I can speak to the fact that it was very confusing for me and many of our staff as to what that meant for us to have a hospice patient on the unit. And it was very, there wasn't a lot of clarity about what our role was versus the hospice, as to who was primarily responsible for the patient, who wasn't, and it left us kind of lacking. And so really the intent and purpose of this video is to help you understand, if you are in that position as a hospital nurse, what your role is and how hospice works and how we all work together. Given that frame of reference, I look back and I think what would have helped me the most at the time. And I think to begin with, as a point to start here, would be understanding what hospice really is. And so I guess the first thing I would want people to understand is that hospice is a change in healthcare philosophy. So throughout all of your life, when you get an illness or something happens to you, you seek a cure. You go to the doctor, you break an arm, you get a cast, you get a bacterial infection, you get an antibiotic. We cure you. It's curative care. But as we age and we get older and sometimes things happen to us, we get something that can't be fixed. And you want to treat it and you want to see if you can be healthy again, but at a certain point, that cure is no longer attainable. And at that point, after you've tried different things, some people reach that point where there's a change in that philosophy. I no longer want to seek aggressive care. I don't want to go to the ER anymore. I don't want to go to the hospital or my doctor. I just want to be comfortable. That really is kind of putting you into the realm of hospice. So we in hospice operate under certain guidelines, and there are very specific things that qualify somebody for hospice care. Qualifying for hospice really falls under Medicare guidelines, and Medicare guidelines puts out a set of what they call the LCDs, the Local Coverage Determination, and it basically lists the subset that you saw of different diagnoses that most people on hospice have. That is not exclusive. Certainly people have a terminal illness that's not on that list and are within the realm of hospice. And so just to kind of briefly go over what Medicare defines as hospice diagnoses, a person that comes on with, and again, these are all end stage. So a person that comes on with ALS, but really are in the final stages of ALS, kind of reach the point where their breathing is affected now, and they're bed bound and so forth. Somebody who's had a disabling stroke, not just having the stroke, but perhaps now bedbound or unconscious or unable to eat anymore. So a disabling stroke. People that have dementia, but not dementia per se, but specific types of dementia like Alzheimer's. And Alzheimer's diagnosis comes with its own scale that rates where somebody is within that Alzheimer's realm. And what we in hospice define as a hospice patient is in the realm of 7A, which means that the patient has come to a point, because it's a very linear progression, but they've come to the point where they can only have a few intelligible words during a day. And then right after that, they lose the ability to walk. That really kind of puts them into the realm of hospice. A person who has end-stage HIV, a person who has heart disease, but again, what we classify for heart disease is someone who's had that echo and their heart is not operating efficiently. They have that ejection fraction of 20% or less, which means they're really struggling to perform daily duties. If they're sitting and talking, they get winded. They can't carry on a conversation because their heart is just not functioning properly. People with end-stage Huntington's disease, end-stage liver disease, people with COPD and lung diseases. And again, COPD is a very difficult diagnosis to put a parameter on, because we find that people that have end-stage COPD, they tend to be very cyclical. They have exacerbations. They get a cold and it really exacerbates their COPD, or they get the flu, and many times they wind up in the ER. But after treatment, they bounce back again. So end-stage COPD really is defined as if they're given maximum treatment, they're on their inhalers, they're on their steroids, they're on oxygen, and still they're declining. That's kind of the realm for hospice for COPD. Muscular dystrophy, again, very end-stage muscular dystrophy. Parkinson's disease, same. The disease has progressed to the point where no longer really ambulating, falling all over the place, a lot of rigidity, a lot of trouble eating. And really eating is a big focus in hospice, because a lot of these disease processes, you get to a point where if you can't eat properly, you tend to aspirate. And when that happens, you get pneumonia and you end up actually passing away from pneumonia. Most Alzheimer's patients end up passing away from pneumonia because they forget to swallow and the food rolls back into their lungs and they get pneumonia and they pass away. And end-stage renal failure is the other one. And end-stage renal failure really is that realm where they've got acute kidney disease stage 5, where they're told that they really need to have dialysis, or they're on dialysis and they no longer want to continue with dialysis. That's the point where without that treatment, they won't last very long. So those are really the parameters that Medicare looks at. But to qualify for hospice, it's when your physician or the hospital says, well, Mr. Smith, given what's going on with you, if nothing changes and you continue on this path, you really have 6 months or less. And that's the parameter. That's all it takes. The doctor has defined your life expectancy of 6 months. Now, nobody has a crystal ball. Certainly, we see it all the time when people come on to hospice and are surrounded by hospice care. They tend to live longer. And all the studies indicate that as well. There's that time duration of 6 months or less. And that kind of defines the qualifier, the order for hospice. The next question then becomes who in that realm doesn't qualify for hospice? And it really kind of boils down to a few typical cases. Certainly somebody who has dementia, but not really end-stage dementia. And that really incorporates a wide range of individuals because, as we get older, we certainly see a whole realm of dementia. But that doesn't necessarily mean that you're going to pass in that 6 months or less. And so we do get orders all the time from doctors to, bring somebody on for hospice. And then it becomes incumbent upon us to go do a full assessment and make sure that that person truly is in that realm, because dementia can go on for a long, long time. Along with that comes a diagnosis that used to be a hospice diagnosis. And again, Medicare changes its rules, but they used to use failure to thrive as a diagnosis, and that is no longer a valid hospice diagnosis. What we do use, which really is the true nature of failure to thrive, is we use something called protein-calorie malnutrition. And family members don't like that because they immediately think, I'm not starving my loved one. But it's not a matter of starving. What ends up happening is, in those end stages of life, your body breaks down. It just does. People can't eat like they used to, and so the body consumes itself. It consumes the subcutaneous tissue, it consumes the muscular tissue, and you become thinner. And so when we see somebody who's lost a significant amount of weight, 10% of their body weight in a couple of months, and they really can't sustain it, and we're talking about frail people who could have skin breakdown because of it, and they have no propensity to heal because they don't have the protein in their body to heal anymore. And if we were to take a blood test, we would see that their albumin is 2.4 or less. These are truly people who have protein-calorie malnutrition, really failing to thrive. And that is a legitimate diagnosis. The other thing that we see a lot of times is people that are referred to hospice and really just need custodial care. Mom is taking care of dad, and mom is very frail, and dad is even worse. And dad really needs somebody to take care of him, and mom can't do it anymore. And so they think, well, hospice is going to come into our home, we're going to be in the home, and we're going to take care of him 24 hours a day. And we don't really do that. We are available 24 hours a day, but we don't provide that custodial care. And so that really isn't an appropriate reason for hospice. So hospice is divided into 4 specific realms of care. And so somebody who is living at home, or living in a group home, or a skilled nursing facility, or an assisted living facility, would receive what we call routine care. That means our hospice team comes to them wherever they live. We're going to provide care in their environment. And the care that we provide is patient-specific. Everybody gets a team based on what they would like. And so they are entitled to a nurse, a CNA, a chaplain, a social worker, the physician, a volunteer, and they can have all of that, or perhaps they just want to have a nurse, or they want to have a nurse and a CNA. So everybody receives a team based on their needs and desires. And so the only real parameter for that is that Medicare says that to be on hospice, a nurse has to make a visit once every 2 weeks. And so that really defines the difference between hospices, because some hospices will follow that rule, and if folks feel, oh, I'm very lucky, I have a nurse that comes once every 2 weeks. Or other hospices like ours, we will give a family 2 visits a week by a nurse, minimum. If they need more, we're going to do more. And so it's really about the quality of care, and having, if somebody wants a nurse and a CNA and a chaplain and a social worker, we can really be in their home, almost every day of the week. But the caveat to that is, again, we're not in the home all day long. We're in the home for an hour at a time. We're assessing, we're talking to the doctor, we're changing meds, we're trying to help them be comfortable. The CNA is giving a bath, keeping them clean, doing some straightening of the environment, again, in order to achieve comfort. Hospice is available 24/7. If you call us at 2 in the morning and you need us to come, we come. But we're not in the home in that time frame. So understanding that most hospice is done in what we call routine care is us providing care in their environment. The next level to that is called respite care. And respite care is a very specific situation, and it is based on the fact that there is caregiver breakdown. Again, going back to mom taking care of dad in the forest or in the community somewhere, mom needs a break. She just can't do it right now. She's just exhausted. And so as a hospice, we provide respite care, which means we take the patient, we put them into an inpatient environment, and they stay there for 5 days so mom can have a break and recover. That's the nature of respite. Respite can't be used coming from a hospital or any other skilled facility because there's no caregiver breakdown. It can't be used to place somebody until you can find a home for them. That's not the purpose of respite. Respite is specific to give the caregiver a break. And it can be done, once a month or, multiple times within a certification period, which I can define later. But, there's no direct regulation that says, you can only have respite once. The next level up from that is called GIP care, and that's kind of the focus of the rest of this video. And really what GIP stands for is general inpatient. And what that means is that when we've come to your home and you have a symptom that's out of control, and if our nurse is there for several hours and talking to the doctor and we can't come to a resolution, we take it to the next level of care. And so we will move you to an inpatient unit, and we will treat you almost like the ICU of hospice. We provide constant monitoring and constant treatment until we can get that symptom under control. And once that symptom's under control, you return to whatever environment you came from, or the alternative is, if we can't get the symptom under control and the person, inevitably passes away. But that's what GIP is used for. It's used for a more intense level of care. The final level of care is called continuous care. And continuous care is the highest level in hospice, and it is essentially the same scenario. The patient has, some symptom that's out of control. However, now we can't really move the patient. And so we're going to provide that care in their environment. So our nurse goes to their home. We have to be in that home at least 8 hours a day minimum, treating that patient hourly, trying to communicate with the doctor to try to get that symptom under control. And once it's under control, that continuous care ends. So those are kind of the 4 levels of hospice. I alluded to certification periods in hospice, and just so a brief understanding of that is that when a doctor says you qualify for hospice, you have 6 months or less, they write that order for hospice, hospice initiates, and we work in what's called certification periods. So we have the first 90 days where we have you on service, and right at the end of that 90 days, a nurse will go out and they'll do a full evaluation and they'll present it to the doctor. And really the guideline for hospice is if you're showing decline, you can stay on hospice. It doesn't matter for how long, it's just decline. If you start getting better, we have to graduate you off hospice. That's the Medicare rule. So we have this first 90 days, the nurse goes out, they evaluate, yeah, patient's still declining. You go into that second certification period. And again, that's 90 days. So after the end of that second certification period, you really have the first 6 months that the doctor alluded to that they thought that you had left on our planet. And if you are still in decline at that point, you go into your 3rd cert and your 4th cert. Only those certification periods are now 60 days, and they are all preceded by a nurse practitioner or a doctor going to your home and saying, yes, you truly are still declining, you remain on hospice. And that can go on for as long as it takes until the patient ultimately passes. Getting into the second half of this, I want to focus more on that GIP level of care and what constitutes that. And I want you to think about it in terms of the patient really has developed some symptoms that require a higher level of care. It requires skilled nursing care. And so we have to bring them out of the environment where they are and bring them somewhere where they're monitored on a frequent basis so that we can treat symptoms, so that we can try different types of medication and see and assess how they're responding to it until we can find a way to get that symptom under control. Now, part of this is done now with the premise that we have two different places that inpatient is done. In most, I don't want to say most, I'm not familiar with all of them out there, but in many cases, hospice uses freestanding inpatient units within the community. But what I'm focusing on here is that environment within the hospital. And in the hospital, what that means is that they've designated a room or a couple of rooms that they're going to call the inpatient unit. So it really becomes a specific environment separated from the hospital in its plan of care. Okay, so now I know it's a weird term to say inpatient because in the hospital, everybody's inpatient. But what it means on hospice is we've literally moved somebody into an inpatient environment. Now, hospice in a hospital is kind of the opposite. The patient has been in the hospital, but now they're going from, again, a curative care into hospice, right? So they're really not going inpatient per se, but in the hospice realm, they are. They're going into that GIP care within the hospital. And so what constitutes someone needing that level of care when they're in the hospital? And really the focus there is, again, that they've determined that this patient is not responding to treatment, that they've opted for that comfort level. They just don't want to fight it anymore. And so they just want to be comfortable. But they are experiencing some symptoms that are out of control. And that can be numerous things. And the main one that we see, obviously, with a lot of our diagnoses is intractable pain. For whatever reason, the cancer has spread. Now it's pressing on internal organs. Whatever their diagnosis is, now we use a lot of different medications and narcotics in hospice, and usually in very small amounts, and a lot of times to help people breathe. Oddly enough, for that vasodilation effect within the lungs, like morphine can be very, very effective to help somebody breathe. But we also treat symptoms of pain, and we treat it aggressively because we don't, again, the premise is somebody being comfortable. We don't facilitate death. We don't give people enough narcotics to kill them. We give them enough to help bring comfort. Now, having said that, sometimes the two are synonymous. A lot of times people don't die when they're in pain. They're suffering. But if given the right amount of narcotics, they become comfortable and they relax and they pass because they're comfortable. And so there's a very big division there because a lot of people think, oh, they're going to give my mom, morphine until she dies. Well, there's some semblance of truth to that, but it's not about until she dies, it's until she's comfortable. And the ramification might be that she dies. Pain is the number one reason that we do GIP, but there are other things. There are times when, for example, a cancer might be pressing on an internal organ, causing intractable vomiting. And we've used all the different antiemetic medications that we have available to us out in the field, and now that patient just continues and continues. We would move them in for that skilled treatment. Frequent seizures, a patient who's seizing on a periodic basis, we obviously, we want them to be comfortable. We want to help them find some some medication that helps minimize or stops those seizures entirely. Somebody perhaps who's had multiple falls and has fractures, pathological fractures throughout their body, and requires, again, pain management and assistance moving with the daily, daily functions of life. Someone who has uncontrolled bleeding that can't be managed and really needs that frequent treatment. And along with that, people who have very complex wounds. As I mentioned prior, somebody with a protein calorie malnutrition, advanced stage could have very complicated wounds, or a lot of times with cancer, we have these fungating wounds that are just really, really awful and require complex changes and treatment on a constant basis. So all of these things require that level of care, along with things like respiratory distress. We can't get it under control in a home environment and they're really struggling to breathe, and severe agitation and delirium. We see that a lot, and a lot of times at the end of life, people become delirious, and it's not that they need to go inpatient for that, but many times they get violent and act out, or are a risk to themselves or their family, and we want to be able to treat that with medications, but we need to do it in a skilled environment. And so we move them in all these scenarios, we move them into this inpatient environment, and they can stay there again until that symptom resolves or ultimately they pass away. Sometimes the two are synonymous in that we've got the patient under control, but death is imminent. Like we know it's going to happen within hours or that day. We don't move them back home. We allow them to stay inpatient. And that's one of the few exclusions to the rule that Medicare has given us, that we can call it imminent death and not have to move someone in that condition and allow the family the peace of having the patient pass without another move. That then comes back to what is not appropriate for GIP, and particularly in a hospital. If a patient has been in the hospital or in the ER and they do qualify for hospice, but maybe they don't qualify for GIP, and now we're going to bring them back to the community. And what would be those reasons why they don't qualify for GIP? I think mostly it's because the patient is showing that general decline, but they don't have that acute symptom that needs to be treated and monitored on that frequent basis. They definitely have that end of life coming, and it's the doctors in the hospital see that, and so there's a difference between actively dying and imminently dying. And so a patient can be actively dying, and really could be actively dying over the course of several days or a week, in which case many times if they're not having those symptoms, we bring them home and they want to go home. They want to be with their loved ones in their environment to pass away. But when a patient is imminently dying, in that it's not safe to transport them, from the hospital, then they really do need to be GIP, because, people want to pass in the environment of their choice, and usually in transport is not one of those choices. Having no caregivers in the home is not a reason for GIP, because that is a custodial issue. It is not a symptom that's out of control. Having a patient that perhaps says, oh, he's a high fall risk, he's going to go home and fall over the place. Well, again, that is a custodial issue. That doesn't indicate that they need that skilled, they do need monitoring, but they don't need that skilled monitoring that requires that frequent supervision and treatment for GIP level. So with that being said, let me kind of paint the picture for you of what the GIP environment looks like outside the hospital. Most of these freestanding units are created with the concept of obviously finding comfort, being in a peaceful environment, being in a place where you're comfortable. And so a lot of these places have very, very nice rooms, plants, music, peaceful environments. There's lots of, sometimes they have, pets that come through, and there's pet therapy or aromatherapy and things like that that help people find peace. Because again, a lot of times, when they relax, they let go and they pass away. In the hospital, it's going to be a little different. I know that in many hospitals, they provide these comfort carts, which have a lot of items to help, provide more comfort to the family. Certainly, sometimes the families are allowed to bring in pictures and stuff in the room that will help them feel more in a home environment. There's going to be some limitation as to what can come into a hospital for infectious reasons and so forth. But again, the idea is that the family or the patient feels comfortable in that environment. So what determines in a hospital environment that the patient goes into their GIP unit? It's usually when they've determined that hospice is necessary, that that patient is following that decline, that they do have 6 months or less. But on top of that, they're exhibiting one of those symptoms that I've talked about, that really they can't go home. They need to have somebody that's monitoring them on an hourly basis until they find comfort. And so at that point, roles reverse. So if you can imagine, in the hospital, the doctors have been in charge of the care. The doctors are making rounds, they're changing medications, they're giving orders to the nurses for wound changes, what have you. They're driving the plan of care within the hospital. It's the hospital's plan of care. When they determine that the patient becomes a hospice patient, the hospice, and in particular GIP, the patient remains in the hospital, but they're no longer under the hospital's plan of care. Now the hospice team comes in and they provide the plan of care. They integrate with the hospital. So again, imagine kind of flipping the environment, and I'd like you to envision a care home or an assisted living facility where the patient lives there, the person lives there, but hospice or home health come into that environment. We come in with our care plan. It dictates that the nurses are coming this often, the CNAs are coming this often, we're providing this medication, we're providing these treatments. It's the hospice plan of care to achieve comfort. And the caregivers in the facility, whether it's a care home or an assisted living, are taking care of that person on a daily basis. They're making sure that they have adequate food, that they're clean, that their environment is safe, and they're monitoring them for safety. So that's essentially what's happening in the hospital environment. So now the patient has become inpatient GIP within the hospital. The hospital staff on that unit become the skilled caregivers. They take care of that patient on meeting their daily needs, their food, their cleanliness, their safety. But the plan of care is now driven by the hospice team. The hospice medical director is the one ordering the medications, is the one that is receiving information from the hospice nurses about changing treatment, changing symptom management, whatever it needs to get that patient comfortable. So it's really dictated by the outside entity of hospice, at the same time integrating with the hospital team. So we really have two teams functioning together. And I think that's really what I'm trying to illustrate the most, because again, in my experience many years ago, that was the most confusing part for me as a med-surg nurse. What is my role in this? And really my role is just to make sure that the patient is safe, that they're receiving adequate nutrition, that they're clean, and that the environment is keeping them functional, and letting the hospice team drive the changes to the plan of care to help reach those symptom management comfort levels. One of the main parameters for the hospice whenever GIP is initiated, one of Medicare's rules state that from the moment a patient is given that GIP level, and really it's a doctor writing an order that says, change of level of care from, routine care to GIP level, or within the hospital them saying, discharge to GIP level of care. But once that order is written, the hospice is mandated to begin discharge planning. We have to look at the situation and say, okay, if we get this symptom under control, where's the patient going? Because now the patient's been in the hospital and perhaps, there's a good likelihood that they will go home. And if they do go home, who's going to take care of the patient? Or are they going to a skilled nursing facility after that? Or are they going to a group home? Or are they going to employ caregivers? Whatever the scenario is, from the moment GIP is initiated, the hospice social worker and the hospice team need to begin discharge planning. And it could change on a daily basis because we work with the family of the patient. Our processes are dictated by what the family wants. And so on day one, it might be that the family, thinks that they can go home, and that's what we're going to be charting to because we need to chart this. And the hospice needs to report on a daily basis. It's kind of a per diem thing. It's a daily measure, and every day we're charting, these are the treatments we've tried. This is the outcome of those treatments. Here is our current discharge plan for today. But the following day, it may change. Now the family says, oh boy, I'm the single caregiver. I can't do it anymore. I'm going to need some non-medical caregivers to come into the home. And so we try to help hook them up with non-medical caregivers in the community. And so that's our new discharge plan. But the point being that it's a fluid proposition, but it's mandated that on a daily basis we're looking at that so that, my God, we've tried this medication and all of a sudden everything's changed. We got the symptoms under control. Now the patient's sitting up, they're eating, they're feeling great, and it's time to go. We have to have a plan in place that day because we can't keep them in the unit, whether it's a hospital unit or a freestanding unit, another day. It's a per diem thing. So that's part of the process. The other outcome, obviously, is that symptoms are really extreme. Hopefully, with all our medications and our external environment changes and our support with our teams and the hospital teams, we've helped that patient reach some level of comfort, and ultimately they pass away, and that's the end of, obviously, the GIP level of care. So with that, I hope I've illustrated some fundamental understanding about hospice and kind of painted a picture of the different levels of hospice and what constitutes, in particularly, GIP care, and more specifically, GIP care within a hospital unit. I thank you for taking the time to watch this video, and I appreciate it. Good day.